So we'll start with the slides, and those of you that have been tuning in to this program up until about a month ago, this was supposed to be Matthew Scott Young talking from Australia, and he had a conflict, and so I'm kind of second choice for the prom date here tonight. But I thought I would give maybe some of his slides as well, but kind of a spiced up version of the introduction to the complications of arthroplasty cervical that we gave at NASS. And again, this is meant to be provocative and discussion provoking. And as I talked to Armin and I just talked to Frank Phillips online, challenge it and let's talk about it and let's see what's what. So we're going to talk about cervical disc replacement 2.0. We've been here before making the case that cervical disc replacement for herniated discs in the cervical spine is now arguably the gold standard compared to fusion. And we've always said, well, fusion's the gold standard. We started out that way 20 years ago, and I think we can make the argument, and I think I've got people here in the room that would agree with that. So now what happens is we're, 18, 20 years down the road, and every disc has a failure mode, and we've seen some of them in different discs. They're all a little bit biomechanically dissimilar, and some are similar. And let's see what we've learned to maybe make this technology in this space even better for patients. Because in my opinion, I think we've raised the bar significantly compared to fusion, and maybe we can even raise the bar within our own discipline of arthroplasty. So, when things go wrong, what do we do? What are the failure modes? So let's start off. And let me make sure I can work this way. Will we do that? All right, we'll use the computer. So cervical disc replacements, as I said, produce at least as good and in many modes superior results to ACDF, and have been well documented. It's one of the most studied spaces in orthopedics and spine that exist. And I talked about the gold standard, so I won't kind of harp on that anymore. But with any technology, adverse events and reoperations occur. They do appear to occur at a lower rate compared to fusion, but we need to learn from these. And as we learn more about these cervical disc replacement complications, maybe we can lower the rate. So what does it come down to? And this is no different than any other technology. Patient selection, wrong patient. Surgical technique, maybe wrong surgeon. Device failure, maybe wrong device. Complications can be related to sizing, positioning, allergic reaction, osteolysis, infection, hypermobility. These are all things that are kind of moving to the forefront of our discussions. So in terms of positioning, does it make a difference? Well, yeah, it does. I mean, when you've got a static fusion, you can be a bit off with your cage, a bit off with your plate, and if it fuses, you're going to have as good a result as if it was spot on right down the middle. The bar is raised, and we need to be technically superior in our surgical approach and technique when we're doing arthroplasty compared to fusion. And in fact, putting the disc in the right place has been substantiated in the literature. This is a study from Special Surgery that showed the better you place the disc, the better the outcomes. And we all kind of know that. We know there's a sweet spot. It doesn't have to be spot on perfect every time, but definitely needs to be within the realm of acceptability. Here's an example from our own practice. This was a patient referred in from, I think it was Mississippi, with a too large device and a pretty hypermobile situation. Fortunately, this patient did not have any neurologic deficit despite the posterior positioning, but was having some neurogenic as well as mechanical symptoms. And we've also learned that a failed arthroplasty doesn't need to be converted to a fusion. Here's one we converted to the ProDisc. I call this the OG, the original ProDisc, original gangster ProDisc. And it's a great revision disc, that's how we rescued this one. All right, what if we combine a couple things wrong? This was a patient with neck pain and paresthesias who had a 2-level Moby done in Florida, who presented for consultation from our clinic. Very typical story. Good early results, but gradual recurrence of symptoms. And unfortunately, which was not detected preoperatively, and we do seem to see this more, and maybe it's just because we're looking for it now, is metal allergies and hypersensitivity. So she was diagnosed with a nickel allergy in a prosthesis that has a titanium alloy with nickel in it. This was preoperative pictures, and again, this is one that we felt could be revised to another prosthesis, which the prosthesis choices are limited in someone with nickel allergy, and this was revised to a simplified prosthesis, which is a Pecon ceramic prosthesis, and the patient recovered well. Device failures, rare in the cervical arthroplasty realm, but they occur, and most occur late, and we've learned from our total joint colleagues to do yearly follow-up. When you've got a fusion and the fusion's healed, you probably don't need to follow them unless they're having symptoms. It's probably not true, and we've learned that from our hip and knee and shoulder replacement surgeons, that you should see a patient every year, or maybe if they get well down the road, every other year. This was a device failure that was reported, a case report in one of the neurosurgery journals, and these are a couple of neurosurgeons from New Mexico who saw a late failure of a case done in Europe, and this was kind of catastrophic because the wire broke into the spinal cord. The patient had a partial spinal cord injury. They rescued the device, but what I'd like to point out to you, and let me see if I can do it with the arrow, what they didn't talk about in the case report are these periprosthetic cysts, which we'll talk about in a bit. I've been calling them osteolysis. They've been called other things by other people, and we can talk about that as we go. So what is osteolysis? Osteolysis, people have been redefining that back and forth. So I went to the NIH National Library of Medicine. Definition is the process of progressive destruction of periprosthetic bony tissue on serial radiographs is seen as progressive radiolucent lines and or cavitation of the implant bone interface. And again, we can talk about in the discussion section. To me, that radiographic appearance, and I'll show some more, meets that definition. These are cases from our own site. This is, again, a case of progressive osteolysis, single-level patient that was symptomatic as well with some neck mass as well. It turned out that there was also some periprosthetic infection as well as osteolysis. We learned from our shoulder colleagues to set our cultures for 2 to 3 weeks for C. acnes, and indeed that seems to be the prevalent bug on these cases of late revisions, late failures, and the osteolysis case. It just seems to be associated in the U.S. Well, the treatment challenge is not all these patients are symptomatic. This is another patient from our site that was basically doing perfectly, and over a period of 5 years had progressive periprosthetic cavitation. I'll challenge anybody to say that this is not osteolysis, but was asymptomatic. And the treating surgeon at TBI got just a bit nervous that the loss of bony integrity might cause a mechanical failure, and eventually convinced the patient to undergo a revision. Probably a good idea. The device was explanted in one piece, and you can see that there's failure at the annulus metal end plate, and that seems to be kind of what we see. But this was taken out as one piece, and indeed cultured positive for C. acnes, though there was no gross purulence. There was just some dark brown tinged fluid. And we actually got histology on this, which showed lymphocytes and some giant cells again. It's been suggested that the diagnosis of osteolysis is a combination of histological and radiographic. This is Matt Scott Young's series in Australia, which was a denominator of 382 patients with cervical arthroplasties, and he had a fairly good number of elastomeric discs. This series was M6, and had a 34% revision rate compared to 3.3% with the others. One of the interesting things in his study, and I want to ask Lisa this question at some point, if not tonight, tomorrow, is he questioned, I'm sure Lisa's read the paper, questioned the appropriateness of how we test artificial discs in general in the FDA standards, but particularly elastomeric, and I think she's probably going to talk about it tomorrow anyway, but if we want to talk about it tonight, the ISO, the ASTM, and she's much more versed to speak about this than I am, so I'm going to just leave it there and leave it really as a question. Here's the revision rate by disc, and you can see there's another elastomeric disc, the ESP disc, which there weren't a lot of cases, but again, high revision rate, and then we talked about the PCM, which is no longer available. So that was his series. His series has been criticized, number one, because a lot of these cases were hybrid type cases, and what would be off-label in the U.S. And the data itself has been questioned, but we'll leave that as it may. So we decided to do the same study at TBI. So TBI, our denominator was not 380 cases, was actually 1,400 cases, patients with cervical disc replacements, and we looked at the reoperation rate as well. And indeed, we found, less than 2%, in fact, even better than the Australia series of revisions or removals, and a number of different reasons. Some of them really can't be related to device failures, but a re-op is a re-op, and I think we would consider that a clinical failure. So, I mean, it's something that we need to talk about. So, osteolysis, we mentioned earlier, it's one of the more interesting modes of failure. We're trying to learn from our peripheral joint replacement colleagues. It's not uncommon. Clinically, is it a relevant thing? Sometimes, but again, a lot of these patients are asymptomatic, and perhaps a lot of them are just mild cases that really don't need anything but yearly follow-up. But we went to look at the TBI cases, and these were not off-label cases. These were all single-level cases. And we found that, again, in the elastomeric series greater than 5 years, our revision rate was 10x, just like Matt Scott Young's cases of our other discs. 22% of the patients who had the prosthesis in more than 5 years had to be revised with, in fact, the diagnosis of osteolysis. You can see the other two prominent discs that we did a whole lot more of with very low incidence of osteolysis. So, in closing, cervical disc replacement has an incredibly strong track record and incredibly robust literature to produce good outcomes and lower reoperation rates compared to ACDF. Knowing and analyzing the complications that do occur can further reduce the complications related to this procedure. For example, which patients are more prone to symptomatic hypermobility? There was a great paper at NASS this year by Dr. Pat Warden that actually defined the sweet spot of mobility. And then there's another paper that's, I think, going to be presented at Cervical Spine Research, a clinical paper that two of our junior partners did at TBI, looking at clinical outcome with different range of motions of arthroplasty. So stay tuned on that. The other question I'd ask, and again, Frank's here virtually, Armin's here, can we agree on the definition between physiologic remodeling and pathologic osteolysis? I think we can. Is there an association with mechanical failure and wear debris? We'll talk about it. Why does there appear to be an increased incidence of C. acnes in retrieved prostheses in our series, for example, compared to the Australia series? Well, because we looked for it. It's a tough bug to culture, and you've got to tell your lab to culture it for upwards of 2 weeks. Osteolysis can occur in any implant, similar to total hips. However, incidence may be higher with certain materials, such as PCU. So the question is there an issue with elastomeric discs? We need to talk about it from both the clinical and biomechanical and wear debris standpoint. And permission to make an analogy. We all know this guy, Johnny Depp. He was involved in a pretty high-profile lawsuit with this woman, Amber Heard. So the question is, are elastomeric discs the Amber Heard of cervical artificial discs. They look pretty good in the beginning. They're kind of fun for a while,
Can't wait.
until which time they might take a poop in your bed.
Ooh.
That's all I have. Thank you.
Lisa, do you want to comment on this? Not the last slide. We'll ignore that. I was waiting for that. So he mentioned that you might have some biomechanical things to say. You can defer to tomorrow or give us some comments right now. Are we testing correctly? And is there a benefit to have some shock absorption in a disc?
Well, you want the truth? Are we testing correctly? No. Why? Because engineers write the standards. But I'm kidding about that. That the problem with the standards are they're setting a set of this is how you need to test, but all the discs are different. The ball and sockets, and we'll talk about this tomorrow, are different even within themselves. You can design the ball differently to get different motions and different parameters. And then you have the elastomeric ones, but they force them to be tested in a specific manner. You must test it in compression, flexion, extension to this degree. You're not taking it to the limits. And there's a lot of issues that I see when companies will, and test facilities will just sit there and say, all right, tell us what to do. We're going to just follow the standard. There's a lot of risks. And the key is understanding the risks for that specific design and incorporating that testing into it as well. And you're still never going to get all of it because the testing on the benchtop part doesn't give you the whole story. And that's why you have to look at potentially animal studies, but they're not the perfect model, and then take it to the clinical arena. So it's really about putting the whole story together and really looking at the risk. Is this material right? They're mixing, let's talk about the M6. They're mixing materials. You're mixing metals with different polymers with different moduli of elasticity and different durometers. And guess what? You have it in one implant, and it's all competing within itself in that one implant. We're not mimicking human tissue. And that's the challenge that we face because it's difficult to mimic human tissue and get the longevity in the implant over time. We'll get there, but the question is, how long is it going to take us to get there?
Great first answer. And we live in a less than ideal world. What is more important to prevent adjacent segment disease from an implant standpoint? Is it maintaining motion, or is it shock absorption? Is there one more important than the other?
No, I don't think so. Because you talk about getting good outcomes with the mobility part. But what happens if these are going to sit in a patient for 20 years? We age. Our tissue stiffens as we age. Now we have something that might be hypermobile. What is it going to do to those adjacent segments? That's always the question. It's like fusion, you get adverse adjacent segment stress because you're too stiff, so the load has to go elsewhere. And you talked about hypermobility being seen, Dr. Blumenthal, in one of the failure modes. So if one level's hypermobile, what are you doing to the surrounding tissue? What happens then? What's going to fail then? And we're not far out enough to know. I'd like to know if you've seen any of that in some of your cases over time.
Lisa, can I ask you, it's a bad question to ask an engineer, but is it possible we're over-engineering discs? And we all sort of want it to be like we were born with. But one of the most successful procedures we do is a hip replacement, and not many of us have a 22 millimeter femoral head, and yet that design has kind of stood the test of time. So I think it's just human nature that we all keep trying to improve things, but maybe we get to a point where we're overthinking it.
Oh, you're right. I'd be the first to say we over-engineer. It's what engineers do. We over-engineer. We want to make the perfect model. So tomorrow I'm going to talk about form following function, right? That's the key. Oh, we want to make it look like the tissue, and then it's going to function like the tissue. And one of my points is that, we're printing cages that look like trabecular bone. Doesn't mean it's going to work that way. You need to be able to understand that performance. So what's more important? mimicking the form or mimicking the function? Can you have both? I'm not so sure you can have both. Well, certainly now, I'm sure we can't because of the materials that we have. We're limited. We don't have viscoelastic materials. We don't have viscoelastic materials that want to work together and collaborate to get the results that we need. Right now, we've got metals. We've got issues with metals, and we've got issues when we're mismatching our moduli with different polymers, et cetera. And our body has to be able to accept that. So I would say, yes, we're over-engineering, and I think we have to take a couple steps back and say, well, we may not want to match the architecture and the tissue and the function, because I don't think it's going to take a long time to get there, let's put it that way. But maybe we can try to match that function and aid the tissue, not overtake the tissue. Because a lot of implants do that. They just overtake the tissue, and that's when things start to fail.
I have a totally, since Jack raised the over-engineering question, totally basic question. We had Dr. Boyce Cheng here, a PhD, Allegheny, and I asked the same question, so I'm not going to tell you what he said, but how many times in a day, and then answer in a year, do we cycle our neck in flexion extension? How many times do we cycle a lumbar spine? Do you have any estimates on that?
Well, they talk about 125,000 cycles of bending and flexion extension per year. I always wondered where they got that from. I mean, you can try to correlate it with, we walk at about 2 to 3 miles per hour. You know, we take so many steps per day. And every time you walk, you know you're cycling your spine. But when you think about your neck, I would think we're cycling it a lot more than perhaps the rest of our body. But, you know, that's a tough one because I question a lot of that. It depends on your activity levels and age and other factors. It's the same as...
Just say it, wait. Okay.
Yeah.
No, but so what does the ASTM then estimate? They have to have some annual performance thing because, again, the load to failure, not the load to failure, the endurance testing is basically done on a conceptualized annual loading thing and perpetuated for a 20-year cycle loading. So what do they think then? Is lumbar spine $1 million a year? Is it?
They think, well, they go through the Mamanian-Hedman data, and so they're trying to say it's 40 years for 10 million cycles. I disagree, you know, and they'll say 5 million cycles is, I think it represents like 20 years. I totally disagree with that because I tend to stay on the very conservative side. So I usually assume 1 million. I've argued this with the FDA multiple times, and it's better to be conservative to say, look, 1 million cycles a year, that's conservative. Those are folks that are in pain. They're not going to be out walking briskly every day, walking fast. They're in pain. They have to have this done. So I bring it back to 1 million. That way, it gives me a big enough margin when you're looking at implants and stuff to say, all right, this load, this many cycles, let's stay conservative so that we have enough of a safety factor in there to estimate, you know, if you get 10 years out of this, you're doing well, and then having to go back in and revise. And do I think you're going to have to potentially go back in and revise? Yeah, most likely, because again, as we age, our biomechanics change and our tissue changes. So,
And our posture changes.
And our posture changes and everything else.
So as an engineer, how heavy is our head? What do you calculate the average head to be, excluding my hydrocephalus? But what's the average?
8 to 10 pounds or 50 newtons.
It's like bowling balls, right? The lightweight versus, yeah.
8 to 10.
Okay. Any other questions on the biomechanics side?
Lisa, as long as you're standing, and this is really more a segue into Frank Phillips' talk, is about the need for viscoelasticity in the lumbar spine versus the cervical spine. You know, it's the same kind of question. Are we kind of overthinking it? You know, we think if you jump off a 4-foot wall, that the lumbar spine's got to absorb a lot more of that vertical force than by the time it gets up to the cervical spine. And yet the lumbar disc replacements that we have now, which have really pretty good clinical outcomes that we'll talk about tomorrow, they're not shock absorbers in any way. And the shock absorber discs that we've tried to start testing have kind of failed for materials failures more than anything else. So, you know, the question that we just don't know is how important is the viscoelasticity versus range of motion? You have any thoughts on that?
Well, I think that's a really good question. I think even the range of motion, we're testing at parameters that you're probably not seeing with implants once they're in vivo implanted for a certain amount of time. I think that we've got a margin on that too. We're taking it somewhat to the limits, but not to where we're failing the device, just the limits of the range of motion. It's not really seen, I don't think, in those patients once they've had the surgery at that specific level. It's shared over the motion's obviously shared over the entire length of the cervical spine, lumbar spine, et cetera. So I think that testing from that standpoint tends to be aggressive. Now, the viscoelasticity, I think you could be right. Do we need it in the lumbar spine or do we need it in the cervical spine? Probably not as much in the cervical spine. But again, are we over-engineering this? We're trying to mimic biology, and we're trying to make it look like biology, and then forcing it to function like biology. And what happens is you go in with this implant that can do anything you can imagine, but it ends up failing quickly and catastrophically because sometimes it's the simple things. You just want to aid the tissue, help offload it, let it heal, and not force it to move the way the implant's telling it to move. Let the tissue do the work and have the implant just help it. And maybe that's the better route. We're trying to overtake everything, we're going to put this implant in and it's going to just solve everything. Whereas, no, we just want to help that tissue heal. I mean, we do that, you have a broken leg, you don't load bear for a little while, it heals, and then you gradually start to load bear.
Microphone. Can you use?
Grab a microphone for the.
Yeah. Just run.
Again, this is a great discussion regarding the biomaterials, and I think kind of to me, from a common sense point of view, it goes back to an analogy I'll make to tires in our cars, depending what we're asking for the tires, right? So if we want a high-performance summer tire, those tires, at least they don't last very long. After 10,000 miles, you're going to have to replace them. And if we're asking something different, perhaps those tires are designed to go 50 or 60,000 miles, which then segues into this next issue of why are we seeing some of these failures? And it seems like if you're looking for them, right, you guys saw them at TBI and I think some of the other places as well, we're seeing infections happening so far out, 5 years out, 6 years out, 7 years out, because I've been doing fusions now for almost 20 years, less and less as time has gone on. When I was doing cervical fusions, it seems like it was one of those things where I almost never, in fact, I literally have a single patient over 20 years who had an infection after a fusion, and that patient was immunocompromised. So in the fusion world, we just never saw infections happening early or late. So then kind of this then goes to next, issue related to, is this, as a firm proponent of this technology, I believe disc replacement is better than fusion, so I'm not in any way questioning that. Is this the Achilles heel of this technology? That is to say, if you have wear particles because you have motion, are you then creating some sort of inflammatory response that then, if there's an opportunistic bug that's hanging around, such as C. acne, may then jump on board and then cause even further kind of almost like a magnification effect of what's going on around it. So I think, again, I'd love to hear either from you or some of the other audience members kind of, and perhaps we don't have the answer to that, and maybe the answer will come to it over the next few years as we kind of explore this issue further and further. But again, it seems like there's these interconnected, approaches of how we think about this that may not be apparent to us right now, but at some point in time, hopefully the picture will become more clear. So
No, I think
biomaterials that we're asking, designing and asking different things, such as cushioning versus motion versus, all the different parameters. And then along with that, what happens as time goes on, as we start seeing polyethylene wear. Over the past year or so, I've been hanging around with some really bright people like polyethylene gurus and, total joint experts. And to them, they're like, yeah, if you have motion, you can have problems. So they kind of look at that as like a given. To us, it's more of a shock because in the fusion world, we just weren't seeing these problems, So
Well, I think that's the point. I mean, there are infections acute infections, staph and strep and stuff that we never see on anterior cervical cases. And certainly there's enough data out there that C. acnes either lives in degenerative discs, herniated discs, or it just becomes introduced at the time of surgery and becomes a biofilm, which could be, in the posterior lumbar world, perhaps an increased incidence of screw loosening or non-union. So I think you got to look at, because none of these patients present with sepsis. They're not sick. So, and their markers, inflammatory markers, are all negative. So I think the late infection thing, I think you said it. I think that it starts off as a mechanical failure. You get wear debris, and in some people, it creates a profligation, if that's the right word, of the, infections, quote unquote, that's not really an infection, it's just a biofilm. Because a couple of these patients we've seen, not only our patients, but ones referred in, actually do have soft tissue masses. But again, they're not sick, they're not septic, so they don't act like infections. And we've converted those to fusions. Those we don't do, if there's infection, we don't do disc to disc. And the stability of a fusion seems to get rid of the infection, because we've consulted ID and they put them on PICC lines and god-awful antibiotics for whatever, and then we've given up now and just treat them with oral doxycycline. Who knows what that does? But I think it's the stability of the fusion construct that gets rid of that type of opportunistic bug, for lack of a better term.
And I think when you think about the constant motion, and this kind of even goes back to the testing part of this, and there are weaknesses in the testing because it's benchtop standardized, so there's things that you're not able to assess, but you've got a mobile implant that's moving every day. As you move, it sheds particulate. As you shed particulate, you change the surface area and you change your implant contours. Now you change your wear pattern because it just tends to get worse because of that change. It just progresses. And so you get to that point where every day that patient's body is fighting off the particulate and constantly fighting that. Maybe eventually it becomes too much. It's dose related. When we look at particulate and we're justifying that as well, they have these thresholds, Cunningham's rabbit model, and all the work they did there, and correlating that 4 milligram of a bolus on animals is equivalent to about 56 milligrams in a 75 kilogram person. But that's just a bolus. Now we're talking about years of constant movement and debris shed, some of it being embedded in the tissue, some of it being shed through the body, peripherally through the system. So what's going on there? What's happening and what are you changing? And we had that issue with hips, but when you think about with hips, metal debris is nanometers in size. We didn't have the equipment to look at nanometer wear until recently. We were only measuring micrometer size debris, so we were missing the smaller debris that can be just as detrimental. Just because it's small doesn't mean it can be shed. You can have a lot of it and it can still cause issues.
I guess the last comment, if I can make before I know we may be running late, is that in the past year since the Matthew Scott Young's paper came out and then some of the reported cases out of TBI, I've also attempted to talk to many other surgeons. I'm just having a hard time wrapping my mind around why is it that, in the case of in Australia and here at TBI, there were these higher rates of reported osteolysis and failures versus just 2 days ago, I was at Eurospine and spoke with Carlson Stewart, and he's been doing M6 for the past 12 plus years with 350 cases with single revision, with more than half of them 7 to 8 years out.
What's his denominator? What's his numerator? What's his follow-up rate?
Yeah. No,
is he following his patients with yearly X-rays?
Every single patient is following them. So I agree with that.
Give us a controlled study. We've got the
I absolutely agree with you. But the same thing with Frank Phillips, who will speak next.
Where we've got the denominator and the numerator.
Absolutely. Yeah. No, I agree with you.
And those patients are all now getting to 5 to 7 to 10 years.
I'm just giving you as someone who's.
But that's anecdotal. You know that.
Yeah.
We try to do capture data, a numerator and a denominator.
mean, but then within that, you have folks like, Frank Phillips who'll speak next, and Rick Sasso, and they're not seeing the same type of changes as well. So I think it just
Frank
comes
has a
back.
case. He presented a case. I mean, and how many did he do in the IDE trial? I mean, what's the numerator and denominator? I mean, it's the data's out there. It just needs to be looked at.
Great segue.